Good day and welcome to ASPA series of educational webinars. Education, upgrading and improving patient care is deeply embedded in ASPA's ethos. We do this by bringing together experts from across Asia. Today's webinar is titled Raising the Bar Beyond Opiate-Centered Pediatric Anesthesia. We hope that you, the audience today, will explore with our panel experts if this practice is a fleeting fad or a practice that is here to stay. Who and why should we practice this? Is there still a case for opiate-based pediatric anesthesia? But before we start, let me quickly introduce myself and my co-moderators for today. My name is Josephine, and I'm a senior consultant the KK Women's and Children's Hospital in Singapore. Teddy is my co-moderator. He's also a colleague. He's a senior anesthesiologist in KK Women's and Children's Hospital in Singapore, as well as Philippines Children Medical Center in Manila. My other co-moderator is Dr. Hang. Dr. Hang is the head of the Department of Cardiac Anesthesia Heart Center in Vietnam National Children's Hospital, Hanoi, Vietnam. And I would like to introduce Dr. Amrita as well. She'll be in charge of the IT. Without her, this webinar would not be possible. Dr. Amrita is Associate Professor Anesthesiology at the Institute of Medical Sciences, Banaras Hindu University at Banarasi. Without further ado, I will let the co-moderators introduce our team of experts for today.
Yeah, thank you, Dr. Josephine, for the warm welcome and greeting to our viewers across Asia and beyond. I am Dr. Hang Nguyen from Vietnam. I am honored to be a part of today's webinar. Before we begin, I would like to introduce the experts who will be our panelists. Our first panelist is Dr. Susilo Chandra. He's a senior anesthesiologist in Herminia Mother and Child Hospital, Jakarta, Indonesia. And next, our second panelist, I would like to introduce our ASPA ASPA presentant, Dr. Vusali Ponder. Currently, she is the Director of Children's Anesthesia Service in Mumbai, India. And last panelist, Dr. Lucy Davis. She is a consultant in Department of Pediatric Anesthesia at KK Women's Children's Hospital. She is the expert in perioperative care and pain management, with particular focus on both acute and chronic pain. He also interested in medical education. Next, I want to talk about some housekeeping. This section is designed as a panel discussion, and we encourage all participants please submit your question and comment through only the Q&A section. Chat and raise hand features are disabled, and we will address many questions as possible, either live or directly in the Q&A. We will also conduct a few polls. Each poll will appear on the screen in 30 seconds. After view the results, please click the close button to return presentation. How about the certificate and survey? The certificate of attendance will be automatically issued to participants who complete the post-webinar survey. It's available 24 hours after the session. Please ensure your full name and email address are entered correctly. Disclaimer: this webinar is for educational purpose only. and is not substitute for professional medical advice. The views expressed those the speaker may not reflect their infused and institute content may not apply to all clinical situation. Now, I will return the main topic today program. I would like to invite Dr. Sulio. Dr. Sulio, please come in. Please, Dr. Sulio. Arita, please check.
No conflict of interest.
Yeah.
Good day, everyone. Today, I would like to discuss opioid-free anesthesia in pediatric patients. Rather than focusing on whether opioids are good or bad, I will focus on more important questions. Do we really need opioids intraoperatively to provide high-quality anesthesia? Modern anesthesia is increasingly shifting from an opioid-centered approach to a physiology-centered approach, where the primary goal is controlling nociception, surgical stress response, and inflammation while promoting enhanced recovery. I have no conflict of interest, only disclosure that since 2021, I have routinely practiced opioid-free anesthesia for all my general anesthesia cases, from neonates to geriatric, from circumcision to complex spine surgery or neurosurgery, from short to long surgery procedure. Anesthesia has evolved from opioid-based anesthesia to opioid-sparing anesthesia, and now to opioid-free anesthesia. Opioid-free anesthesia is not a rejection of opioids. It is simply the next step in balanced anesthesia, using multimodal technique to reduce adverse effects and improve recovery and patient outcomes. This is the key concept, the most important slide of my presentation, that pain and nociception are not the same. Pain requires consciousness, whereas nociception is simply the neural process of noxious stimuli. During general anesthesia, patient cannot perceive pain, but surgical stress, sympathetic activation, and inflammation still occur. Therefore, our intraoperative target is nociception rather than pain itself. Nociceptions occur due to surgical stress, hormonal reaction, and sympathetic reaction, as well as inflammation, which can also be treated by the drugs other than opioids. This distinction forms the conceptual foundation of opioid-free anesthesia. Our goal is not simply to administer opioid whenever heart rate or blood pressure rises. Our goal is to control nociceptive input and the resulting physiologic stress response and also inflammation. Traditionally, opioids are used for analgesia, hemodynamic stability, attenuation of stress responses, and synergy with anesthetic agents. These are valid reasons, but they are not unique to opioids. Tachycardia and hypertension do not automatically indicate pain. They may be reflect from hypovolemia, inadequate anesthesia, hypercarbia, or other physiological disturbances. Opioid-free anesthesia encourages us to identify the actual causes and treat it appropriately, rather than reflectively administering more opioids. Opioid-free anesthesia encourages a more physiological interpretation of intraoperative events and more targeted treatment approach. And now the evidence is catching up. No opioid, better recovery, less complication. This is no longer experimental. Opioid-free anesthesia is a multimodal anesthetic technique that provides adequate anesthesia and analgesia without perioperative opioids. The goal is to control nociception, sympathetic activation, and inflammation while supporting enhanced recovery. Common components include regional anesthesia, IV local anesthetics such as lidocaine or lignocaine or xylocaine, alpha-2 agonists such as dexmedetomidine, and MDA receptor antagonists such as ketamine, magnesium sulfate, and don't forget non-opioid analgesia like NSAID, paracetamol, gabapentinoid. No single drug replaces opioids. Instead, multiple interventions work together to achieve balanced anesthesia. If opioid truly solve every aspect of perioperative nociception, this slide would contain only one box labeled as fentanyl, and we could close this webinar earlier. Unfortunately, nociception, inflammation, and surgical stress did not receive that memo. Therefore, modern opioid-free anesthesia relies on multiple complementary pathways rather than repeatedly pressing the same opioid button, hoping physiology becomes cooperative. Opioid-free anesthesia is particularly relevant in pediatric patients. Neonates have immature hepatic and renal function, reduced drug clearance, and altered pharmacodynamics. This characteristic increases susceptibility to opioid-related adverse effects, especially respiratory depression. OFA has potential to minimize this complication, maintaining effective perioperative analgesia. In conclusion, opioid-free anesthesia is safe and effective in pediatric patients for a variety of surgical procedures, provide adequate pain control, and reduce the risk of opioid-related adverse events, faster recovery times, and reduce postoperative sedation. An interdisciplinary approach involving anesthesia provider, surgeons, pediatrician, and pain management specialists is essential to ensure comprehensive and individualized care for the pediatric patient undergoing surgery without opioids. Opioid-free anesthesia is not simply anesthesia without opioid. It is a multimodal strategy designed to control nociception, reduce surgical stress response, and improve recovery. Lesson learned from
Thank you very much, Dr. Susilo, for that very thought-provoking and insightful presentation. Before we move on to our case discussion, I'd like to hear from our audience. After hearing from Dr. Susilo's lecture, we have prepared our first poll question for this afternoon. So let's say, for example, right, in your current practice, how often are opioids used intraoperatively for major pediatric surgery? Do you routinely use it for most cases? Use selectively when clinically indicated? We actively minimize opioid use whenever possible? Or opioids are rarely available in my institution, therefore I will not going to use it. So while our viewers are answering these questions, maybe I'd like to explore one of the central themes raised in Dr. Susilo's presentation. And as the fields moves towards from opioid sparing and then opioid-free pathways, an important philosophical question emerges when we replace opioids, like what Dr. Susilo highlighted, right? Dexmedetomidine, ketamine, and some advanced sophisticated regional anesthesia techniques. Are we truly changing the paradigm of analgesia, or are we simply changing the drugs that we use? So maybe to dig deep into that, I will ask Dr. Susilo, should our primary goal be eliminating opioids at all or minimizing opioid-related side effects? Dr. Susilo, what's your take on this?
Thank you for the question. My 5 years experience in all my cases, I use opioid-free anesthesia. Teach me that virtually we can do all cases without opioids. But for the new kid on the block, from the beginners, it is better that opioid sparing first. Then if you already recognize what is opioid sparing, then you can try simple case, not difficult case for opioid-free anesthesia. Then you know.
Dr. Susilo? I think there are some hanging in the, but yes, we get the idea. I think Dr. Susilo is trying to engage us that if you are starting anesthetists, you can start from opioid sparing. Yeah, Dr. Susilo, we
Unstable, yeah.
Yeah.
Okay.
Very
I
much.
experienced that one of my case is extremely difficult case from spine surgery. It lasts 6 hours. All I did without opioid at all, and post-operatively, also I didn't give opioid. I gave lidocaine drip for 24 hours, and the patient went home the third day after surgery, and a week after that, surgeon meet the patient, and a couple of days after that, my surgeon asked me. It's very difficult to answer actually because this is the first case. Maybe it is the 2022, so only 1 year experience. Then he asked me, Dr. Susilo, what did you give to my patient? I am not directly answer the question. I asked him, why you ask that question? He said, my patient is not experience pain at all when it come to control 1 week after surgery. So from that, I never use the opioid again.
Thank you.
But again, for the beginners, don't do that.
I think the best, I think the message with Dr. Susilo is engaging to us is that you try or start with opioid sparing, then slowly transit to opioid free once you mastered all of these adjuvants that we can use as alternative. But however, right, all of these adjuvants that we have mentioned just now is not devoid of any side effects as well. So then if a child receives multiple non-opioid regimens, right, with their own side effect profiles, can we confidently say that the overall treatment burden has been reduced? How about, what's your take on this, Dr. Brushali? I can see that you are very engaged with this question, right? So if we replace opioids with something else, but of course the something else is always have their own side effects, have their own caveat in terms of taking it in and prescribing them, have we really considered ourselves successful in treating the child?
What I suggest is we just change the entire paradigm a bit and say that what if we want a recovery of this kind? And let's start imagining. We want a baby or a child or a toddler, adolescent who is comfortable, who is pain-free, relatively pain-free, at least clinically relatively pain-free, no nausea, no vomiting, no hyperalgesia, and mobility is also not restricted, no pain on movement. So if we want all this together, then let us see where the balance is tilting. Then the balance is tilting towards multimodal and having a regional anesthetic as the main fulcrum around which all this is then looked into. So it's definitely multimodal way to go, and there is no one answer to give for pain relief, as even Dr. Sushilo said in his lecture, that it's
I can gather that what
multifaceted.
you're suggesting is that we need to identify the endpoints that we are trying to achieve
Yes.
for this particular case, regardless of what pathway we chose, whether it's an opioid-free or opioid-sparing, as long as the endpoint that we have set for the patient has been achieved. So I just go back to the poll question that we shared just now to our viewers. In our current practice, majority of our viewers will actually choose, still 49% will still routinely use opioid in most of their major pediatric surgery cases. I hope after this webinar, we might change some of the views of our viewers, and we managed to invite others with this philosophy as well. So in order for us to dig deep into our this presentation, we'll have two cases that we will share to everyone. Our first case I will share with you. Okay, so our first case, we have here a 7-year-old boy undergoing major foot reconstruction with iliac crest bone graft harvesting. So before we discuss the specific analgesic strategies, right, we need to identify first what are the challenges that we have. So this patient have developmental delay, is a hyperreactive behavior, difficulty in cooperating with examinations and procedures. Then, of course, the orthopedic team anticipates a significant post-operative pain and hospital stay about 2 to 3 days and need for physiotherapy and early mobilization. So I think these are the key things that Dr. Bruchali mentioned earlier on as our endpoints that we wish to have. So as we consider, now before we start and discussing this, I have another poll question to our viewers. Okay, let me share our poll first. So our second poll to our viewers is that, all right, so our second poll for this type of surgery, right, is a major orthopedic surgery. Which analgesic approach would you closely reflect your current practice right now? Okay, so the first, of course, is systemic opioids with multimodal analgesia, single shot regional anesthesia with multimodal analgesia, or you're going to consider continuous regional anesthesia plus multimodal analgesia, or you just use a predominantly opioid-free strategy, or you're not sure, depends on institutional protocol and resources as well. Okay, so we will give our audience to answer this question. Okay, but while we are waiting, maybe I will call Dr. Bruchali. And for this particular case, right, what are your primary analgesic goals for this child? And just to follow up on that, right, I understand that this patient, as highlighted by orthopedic team, right, significant post-operative pain. But what other pain targets are we anticipating for this particular patient?
Yes, predominantly it's of course the bony pain, the musculoskeletal pain that we are looking at. And the best way to curb musculoskeletal pain is of course a regional block. So it could be the mainstay, as I mentioned even earlier, is going to be a regional anesthetic, and that to a continuous one, because we are dealing here with a child who is challenged in communication, Not that he cannot communicate, perhaps he's communicating in the best way that he is able to. We don't understand the way what he means by his communication. So I guess that's the best way to go. And then try to curb pain at every point that it emerges from. The acetaminophen can be given periodically, should be given periodically. NSAID, there is no contraindication here. And suppose if I go with all my enthusiasm to give a regional block along with general anesthesia, and the surgical incision is taken, and there is a rise in heart rate, although I have given enough of soakage time for the block to act, I must accept that, look, the RA has failed. I will pick up opioid at this time, and I would give opioid because my target is not to not use this or use this, but my target definitely is do all it takes to give excellent pain control in the intra and post-operative period. So I think we should go all out and see what we want to achieve and go by that. And then the same case, if we finish and I know my block is not giving what it gives me usually, then I will think of a rescue block at the end of the surgery.
Yeah, thank you very much, Dr. Brushali. I'm just going to share the result of our poll. We survey our audience right now, and 46% of them will actually use a single shot regional anesthesia plus multimodal. And equally, 24% will have a systemic opioids with multimodal analgesia and continuous regional anesthesia plus multimodal analgesia. You mentioned about continuous regional anesthesia specifically for this case. Based on your experience, for this type of surgery, can this surgery be done without opioid if you are going to give this patient a continuous regional anesthesia? And if you are going to give what particular regional anesthesia? I'm sure you are our regional anesthesia expert. That's why I'm asking you these details about what type of regional anesthesia you're going to use. And if you're going to use a continuous regional anesthesia, what local anesthetics are you going to give to our patients as well?
Fine. We will plan it properly. In the sense here, it's foot. So we can actually go peripheral, or we can stick to our good old central neuroaxis block as well. So it can be sciatic and given by either a saphenous or a femoral, because with single block, we cannot give anesthesia to an entire lower extremity, but then we would spare iliac crest here, which is a very powerful pain generator in the post-operative period. So maybe we can give a QL. What I had given in this case was a continuous sciatic and QL with an additive into it. A single shot QL. However, epidural is also a good choice if we do not bank on continuous peripheral nerve block such as a sciatic, if somebody doesn't want to do that.
Yeah, you mentioned about additives, Dr. Brushali. What usual additives you use for this? Let's say if you put a sciatic block, regional continuous.
What we can do is, our primary block is a sciatic block. So we'll put a infusion here because that's the main pain generator. Right. Then we would go to QL. Here we will definitely put an additive. And QL is a plain block, so it is going to require a bigger dose. Now let's handle one by one. We go to sciatic. He is around 7 years. He is around 32 kilograms. So how much of local anesthetic can I use? I can definitely pick up 0.2% propivacane, almost to 25 ml to 30 ml. I am not exceeding the dose. I'm not going to exceed the dose. I'm going to tag my syringe with, say, clonidine 2 microgram per kilogram, the most approved of the additives that we know of today. Having said that, let us start with an ultrasound guided or a PNS sciatic, maybe a popliteal because it's a foot surgery. Okay, let us go with ultrasound or PNS, whichever. Once if it is ultrasound, we are going to see whether the nerve is floating there. If it does, I would stop my injection, typically 10 to 15 ml, and then would go with the 2E needle, or whichever way you want. We can put in a catheter. We don't want a catheter, the additive is there. We'll give analgesia at least for 10 hours or some, for sure, because peripheral nerve blocks are prolonged analgesia. Yeah. Give around, say, 5 to 8 ml in the femoral nerve, and the rest actually can be given in QL because it is a It is a plain block, so it requires bigger. So everything gets stacked with clonidine, and the primary site gets a continuous catheter.
Thank
And
you
here
very
the
much,
prop-
Dr. Ali, for
yeah,
the very nice
and
tips. Yeah, clonidine 2 microgram per kg, is it? Yeah, as an additive.
yes,
Yeah. Then okay.
and you
Hmm.
know, with peripheral nerve block, there's going to be another small practical problem. It might be big also to somebody. The surgeon is going to tell me that I am going to apply a plaster even above knee
Okay.
after
Exactly.
the foot
That's my next
correction, all
question.
right? So what do I do with your catheter before that? Let the catheter be. The surgeon is going to get the patient back 8 days after to redo the plaster, change of plaster. That's the time you can pull out the sciatic catheter. The plaster will protect the catheter.
Yeah. Thank you very much, Dr. Brushali, for the important tips. I think we learned a lot from that. You mentioned earlier on that you will still going to give opioids at a certain point in time, right? Yeah, but then I would like to ask when, actually, what are the turning points wherein you will give patient opioids if the patient is already in continuous regional anesthesia? Let's say, for example, the patient is already on post-op day 1 doing physiotherapy and started to experience a little bit of pain. So can you give us some tips, or what are your threshold? When can you say, okay, I can still carry on with my continuous regional, I can do these things, I was still not going to give morphine, or what other things that you can give? Then when will you give opioids for this group of patients so that our viewers will know?
Teddy, I can see that you really reflected on this entire concept to come up with this question. There is one turning point and only one that I can see. If the RA fails, and that too intraoperatively, I am definitely going to turn towards opioids. Now, when it comes to physiotherapy, till the limb heals, the physio is not going to happen because they are going to keep a plaster for quite some time. At least for 15 days, this kind of a correction is going to take. It's not a fracture which has been reduced. It's a total correction. So it will take that much time for the physio to set in. So then we are going to think of paracetamol and NSAID before the physiotherapy, maybe 40 minutes or half an hour, so that the peak effect is there for the physiotherapy to be aided with. Perioperatively, if the block is giving its good analgesia, a continuous one, good analgesia, acetaminophen and NSAID, intraoperatively given dexamethasone, all this is stretching out over and working well, I do nothing. If it doesn't, I can then escalate paracetamol dose, because if it's TDS, I can make it QID there and then. Or I could go to an opioid which is fair enough to go on a floor, maybe such as, okay, fentanyl, all right, tramadol, but not unless I'm pushed to give. I would really spare it. And most of the times I do without it, because at least in India, opioids are not rampantly available on the floors, and people are going to be more scared about their side effects than their good effects.
Yeah. Thank you very much, Dr. Brushali. And I think good point. I think timing of medication, regardless whether this is a paracetamol, ibuprofen, all of this must be given before a very impactful, a very painful mobility comes, like mobilization and rehab and all of those things. Yeah, that's a very good point. I think at that particular point, we managed to understand when are you going to give opioids for this group of patients. So my follow-up question, let's say, for example, for this case, you have given or prescribed a tramadol or a fentanyl as a rescue medication. Should opioid administration be viewed as a failure of opioid-free pathway? Maybe I'll ask Dr. Lucy regarding this point of view. Let's say, for example, for our case, if let's say you have put in a catheter, is doing very well, and then post-op day 1 comes, physiotherapy, maybe for the first attempt, it's okay. But midway through the mobility, patient complained of severe pain, they cannot carry on anymore. Then you ended up giving some fentanyl as a rescue. Can you consider that giving fentanyl at this point of the patient's mobility and status or clinical scenario is a failure of treatment?
I don't think we're ever going to consider it as being a failure. because after all, the goal here is patient comfort. And we are trying to minimize opioids actually for patient comfort and for improved patient outcomes, to reduce opioids related side effects. And ultimately, we are trying to get the patient moving again. We're trying to get the patient moving faster. And if it takes giving opioids to get the patient moving, then I think that's absolutely fine. And I think one of the Q&A has been that the practice is not to give morphine, but to give fentanyl, and that's fine as well. Giving short-acting opioids is absolutely fine. But the thing is that when you've given a regional anesthetic technique, you should always go back to troubleshooting your regional anesthetic technique, because ultimately that regional anesthetic technique was working, and then it stopped working. Is there a possibility of actually troubleshooting it?
Yeah.
Add in here.
Dr.
So,
Bush?
yeah, can I add in here? There is a red flag that we all need to consider. Yes, I absolutely taken with Lucy and what Dr. Sushilo said a while ago. The goal is minimize or spare opioid and keep giving all other modalities. However, coming to RA, if my infusion is giving a good pain relief, not in this case, any, and the physiotherapist is going to come, I might strongly consider giving a bolus half an hour before the physiotherapy. So over and above the infusion so that the patient is comfortable. However, if on a given regimen of an RA infusion, local anesthetic infusion, and the other multimodal approaches that we are taking, if at one point, say 24 hours later, the child is comfortable, but after that, the child is grumpy, uncomfortable, irritable, I would not escalate anything. I would ask the orthopedic surgeon to go and see for plaster fullness, or if now it is heralding a compartment syndrome.
I see. Yeah. Very good point, Dr. Brushali. I just have one question, right? You mentioned about giving bolus and all that. So when you give bolus, how much bolus actually you're going to give it? Is it depends on the patient's height, weight, or how you're going to administer the bolus of regional anesthesia for this particular patient?
Weight, of course, for sure. Generally, say for a 7-year-old, our infusion is going to be 2% ropivacaine in a dose of, say, 5 ml per hour to maybe in the range of 5 to 7 ml per hour is what I would give, which is absolutely safe along with multimodality. Now, if I know that this particular person is going to be attended by a physiotherapist very soon, I can still give a bolus of, say, 0.5 ml per kilogram right now and wait for half an hour and then let the physiotherapist come over. Or give a paracetamol, wait for a while and let the physiotherapist come over. As long as milligram per kilogram per hour dose is not exceeded, we are fine to pick up a bolus between.
Yeah. I think for this particular case, right, one of the things that is being shared to us that this patient do have some neurodivergent. Is a neurodivergent patient with some delays and all that, high likely will not be able to communicate pain as well. So for this patient, right, how are you going to determine your success? How can we actually define our success in terms of opioid-free or opioid-sparing approach for pain treatment for this child?
Because of the communication issues, still, I think it is the primary caretaker who is going to help us bridge the gap between what we don't understand and what the child is going to tell us. Because they definitely are going to understand the pain behavior of the child. The child here was an autistic child, was very hyper active. However, the mother was very helpful in making us understand. This happens most of the times in any any disorder as such as any disability such as cerebral palsies or autisms, or in all those ranges. Secondly, is the child eating well? The amount of food that the child eats before the operation if it's almost equal to the same, more or less you're on the correct path. If the child sleeps well. So if these three conditions are fulfilled, fair enough. And I think we underestimate the way they communicate. If you're sensitive enough, we do understand that they are in pain and they generally do not like doctors to be around. So you have to take the the primary caretaker a little away and quiz them about what their behaviors are.
Yeah.
And there are proper scoring systems for these
I think
subsets of people.
I agree with that, Dr. Brushali. You highlighted one of the most important things that we should always put forth in managing this group of patients is communication. Because the reality, right, when this patient shouts or this patient has some behavioral or throw some tantrums in the wards and once surgery is done, the initial instinct we always think is always pain. And the instinct is to, oh, my regional is not working, I'm going to get fentanyl. I'm going to get opioids. So I think dissecting and communicating well with the parents and the actual caregiver who can provide us information how the patient behaves in a painful situation will give us more idea of what is specific targeted treatment that the patient requires. Does this patient will require anxiolytics? Will the patient benefit more from clonidine or will benefit more from other medications apart from opioids as well? And whether this patient will benefit from a non-pharmacologic approach, or whether some non-pharmacologic therapy that will even avoid any side effects of any pharmacologic intervention that will benefit to the child. A very interesting and thoughtful conversation with everyone. But before we conclude this particular segment for this particular case, let me ask one more time for our viewers with another poll question. After you have listened to Dr. Brushali, Dr. Susilo, and Dr. Lucy in their point of view regarding this particular case, I would like everyone to complete the following sentence. For major pediatric orthopedic surgery, opioids should be a routine. It should be expected to be given, available when needed, reserved for rescue analgesia, or rarely required at all. So maybe with that, while our viewers are answering, perhaps the real question is not whether opioids whether opioids have a place in pediatric anesthesia, but rather when, why, and for whom they remain the right tool as well. Like Dr. Indo Sen mentioned earlier on, and even Dr. Serene Lim, our pain guru back in KK, it's not the drugs that we use, it's how we use them. So I think I will end the poll and share the results to everyone. After that discussion, 40% of our viewers answered that opioids should only be available when needed and reserved for rescue analgesia. All right. Thank you very much. I think our first case is already quite challenging because it's a major orthopedic surgery. So, and to think about opioid-free pathways in a major orthopedic surgery is really quite interesting. And Dr. Brushali gave us some good tips with continuous regional anesthesia. So let's now raise the stakes. Okay, so our next case moves beyond orthopedics into a pediatric oncology, where the surgical insult is greater and there's a visceral pain becomes major component, and recovery goals extend well beyond and pain scores, mobility, and sleep, and nutrition and feeding and that. Okay, so I'm going to share the next case. Okay, so our next case is an 8-year-old girl undergoing open abdominal neuroblastoma resection following a neoadjuvant chemotherapy. This involves extensive retroperitoneal dissection, significant visceral manipulation, and a large abdominal incision, and anticipated moderate to severe post-operative pain. She also has a history of chemotherapy-associated nausea and vomiting, and multiple prior hospital admissions, contributing to significant pre-operative anxiety. So our recovery goals, okay, like mentioned in here, is that we are aiming for, of course, effective analgesia, early mobilization, and of course, enhanced recovery. Okay, But achieving all four simultaneously may be considerably more difficult in this particular case. But before we discuss thoroughly, I have another poll questions to our viewers. So my question to our viewers, give me a minute. I'll stop share this and I will launch our fourth. Yeah, so for the child undergoing open neuroblastoma resection, what will be best describe your usual approach? Is it traditional opioid-based analgesia? Is it multimodal analgesia with moderate opioid use, or regional anesthesia with opioid minimization? So these are the three options. So while you are all answering, maybe I can ask Dr. Lucy, right? When you first see this case, right, what immediately concerns you from a perspective of pain treatment and prevention?
I think what we're aiming for here would be early mobilization of the patient. And I mean, obviously, you're trying to optimize all of the recovery objectives, having good pain control, having an enhanced recovery. But I think when you talk about these sorts of patients, you're looking at getting them moving. And part of the problem with these patients is that they've had multiple procedures in the past, and their pain is very layered. And it's not just purely going to be a strategy where you're focusing on pharmacological therapies, but it's also a case where you are going to have to explore non-pharmacological therapies, because here you're dealing with cancer pain, and cancer pain is complex.
Yeah. Thank you very much, Dr. Lucy. Yes, I agree with you that this is particularly very complex because it involves quite a number of things. I'm going back to our poll questions that we just shared, and I'm going to share with you the results. And it's a 50-50 answer. 50% answered multimodal analgesia with moderate opioid use, and 50% answered regional anesthesia with opioid minimization. Dr. Lucy, what are your thoughts? What do you think about your approach for this particular patient?
Yeah, absolutely. I think when you're dealing with this kind of case, you really want to actually use multimodal analgesia. And like I mentioned earlier, it's not going to be just pharmacological. You're also going to employ all the non-pharmacological strategies. But when it comes to pharmacological, I think employing a regional anesthetic technique would be your best chance of minimizing opioids. But having said that, you have all of these other adjuvants that you can consider using as well. So you've got the alpha agonists like clonidine, dexmedetomidine. You've got ketamine, and then of course you can also consider using IV lignocaine. You can consider using magnesium, bearing in mind that in the pediatric population, the data is still building and the research is still required. But there's been very good data in adult populations, and we're starting to see data emerge in pediatric populations.
I just want to dissect more on the IV lignocaine. When and what particular scenario will you actually start an IV lignocaine? Are you going to start it as an intraoperative intervention, or you will wait until the pain is significant postoperatively, then you will start?
No, typically you actually have to try to prevent the pain wind up. So you're going to start this intraoperatively, and you're going to continue it into the postoperative period for it to be effective. In adult populations, this has worked very, very well. And in patients undergoing abdominal surgery in particular. But there is also, some evidence that it is working in pediatric populations as well.
I see. So if you're going to start this intraoperatively, any tips and suggestions for our viewers? What's the dose like? What's your loading dose? And if you're going to carry it out, what's the maintaining dose as well for IV lignocaine infusion?
So typically a loading dose would be between 1.5 mg per kg. You would load that, and then you would actually start an infusion of 1 mg per kg per hour. And that would be a safe dose. I mean, of course, there's a range. You can choose to go, 1 to 1.5 as your infusion rate. And some people would go up to 2. But again, you would have to ensure that you have appropriate monitoring for the patients because, of course, you're not without risk in this when you're using IV lignocaine.
Yeah, you mentioned about monitoring and all that. And is there any prerequisite that you need to prepare before you start this patient on IV lignocaine? Are there any qualifiers? What is your inclusion criteria for patients who can we safely start an IV lignocaine infusion?
Yeah, you do need to be able to appropriately monitor the patient because, of course, when you're running a local anesthetic infusion, even when we're running at these rather safe doses, we do worry about the development of local anesthetic systemic toxicity. And so you would actually need protocols in place to appropriately monitor the patient for hemodynamic stability and also for the onset of the early side effects that you would see when there is toxicity, particularly things like the perioral, tingling and numbness. And so when you're talking about the safest patients to use it in, I would say that you would aim to have it in verbal patients and patients who are able to communicate, which your pediatric population may not always be able to. So patient selection is important, and choosing the patients that you would want to employ this technique in.
Yeah. Dr. Susilo, you mentioned earlier on that you actually use lignocaine infusion to one of your patients. Would you like sharing your experience with lignocaine infusion? When did you start during the perioperative journey of your patient?
Yeah. Usually, as Lucy mentioned, that we start from loading dose first. We can start 1 milligram or 1.5 milligram per kilogram body weight before induction or during induction, and then continue with 1.5 to 2 milligram per kilogram body weight per hour. And don't forget to combine because should be multimodal, so you can also adding ketamine drip. You can also give magnesium sulfate and gabapentinoid before surgery. This is important so to make sure that we don't make IV lidocaine become toxic because the dose is too high.
I see. So you are going to start or give lignocaine for the 24 hours, and on top of that, you will start ketamine infusion as well.
Yes. Yeah, the dosage is very low, 0.6 milligram per kilogram body weight
6
per
milligrams
hour.
per hour.
Per hour. It's very low. And it is good. Yeah. 5 years experience say that this is good for the patient. Also, don't forget to combine with NSAID and paracetamol as well.
I see. For this group of patients, Dr. Susilo, will you discharge this patient if you are on ketamine infusion, lignocaine infusion in your institution? Do you discharge this patient in a regular ward, or you send them to a special ward like high dependency or ICU after the procedure?
Usually we do send the patient to high care unit.
I see.
Yeah.
Mainly because of the infusions and all that. My concern is mainly the dose of the ketamine, which is 6 milligram per kg per hour, you mean, for the infusion?
For adult. For
pediatrics, how do you actually use it?
Smaller than that. Yeah, maybe only 1 or 2 milligram per hour. Not per kilogram body weight.
I see. And you don't have issues with dissociation or any behavioral changes with that dose as well. I see. You mentioned also about magnesium. Maybe I go back to Lucy. Lucy, you mentioned also about using magnesium for this group of patient. Then same question with lignocaine. When do you use your magnesium? Do you start it intraoperatively, or you just give magnesium as a rescue when everything else fails?
No, again, I think you would want to start it. You would want to start it intraoperatively, but rather than using it as a rescue. But it has to be said that when you're using magnesium, I think the evidence when it comes to the opioid sparing effect in pediatric patients is much less robust than it is in adults. But it does still show promise, and there is still data building. So if you wanted to use it, you would actually want to start it intraoperatively, and then typically I would say that actually you wouldn't actually need to run it as an infusion postoperatively. You would give it intraoperatively while you are monitoring the patient.
I see. Then any suggestion on how we start magnesium intraoperatively for this case?
So you can give a loading dose over about 15 minutes, which is 10 mg per kg per hour. You would actually give a loading dose of about 30 mg per kg. And then you can then continue infusing at 10 mg per kg per hour during your operation.
Then after surgery, are you going to continue magnesium outside operating theater, or you will stop in?
No, I would say that it would be safest to stop.
I see.
Yeah, because if you were to continue post-operatively, you would create a lot of logistical challenges for the ward in terms of the monitoring, because it does require quite intense monitoring for IV magnesium.
Yeah, Dr. Brushali, any thoughts on magnesium? Yeah, you're muted, ma'am.
Not really. My thoughts are away from magnesium. I was waiting for Lucy to finish with magnesium, and I wanted to take you a little away from lignocaine and magnesium. Not away in away sense, but I was just trying to put some other perspective.
Okay. Yeah. So I think one of the things that we highlighted just now, there are two critical medications that actually we really dissected the potential role as a replacement for opioids for this particular case. And it's very nice that both of our speakers managed to share with us on how we actually share or use magnesium and lignocaine intraoperatively and all that. One of the things that we wanted to been discussing the whole afternoon is about the role of regional anesthesia. I think I'll go back to Lucy again and ask, for this particular case, right, what regional anesthesia actually would you actually consider giving to the patient?
So there's actually there's a lot of options. You can consider central neuraxial techniques. You can consider giving peripheral techniques. You can even consider intrathecal morphine if you wanted to use opioids in a very minimal way. And you could even consider putting in wound catheters. Which has actually been quite effective, and those wound catheters, they can sit in situ for 72 hours or more, and provide ongoing pain relief in the post-operative period. Yeah, so yeah, there's many different options, and maybe Dr. Brushali can also give her take on that.
Dr. Brushali, for this case, what regional anesthesia technique would you recommend?
Yes, actually, that was what strongly was going on in my mind, where Lucy and Dr. Sushilo were speaking about Maxalf and lignocaine and ketamine. Of course, they're wonderful adjuvants to go to. However, they're not site-specific as such. Surgery such as neuroblastoma, we would really do very well with a lower thoracic epidural, so that it becomes extremely site-specific. It gives analgesia, which is visceral as well as somatic. It would work so well as a continuous infusion in the post-operative period. It would give a hypovascular field, also can minimize blood loss because of hypovascularity itself. And the rest can be actually used, if at all, as adjuvants. But of course, if for some reason, if epidural is contraindicated, then all that we have discussed as alternatives for a central neuroaxial block and lignocaine and Maxalf, they all are wonderful alternatives.
Yeah. All right.
The incident is going to be huge. It is a very major surgery. I think the take-home message should be very clear. go to a strong site-specific regional block if one can, in which case, this case is an epidural. Or then Lucy just said about the peripheral nerve regional anesthesia, keeping catheters in the wound, coming up, not as that established in children. Sushilo and both of them were mentioning the other ones, such as ketamine, dose 0.1 milligram per kilogram per hour in the postoperative period, maybe. Yeah.
Yeah, I think there's one question in the Q&A, I think channel to Dr. Susilo. Will you give midazolam when you use ketamine infusion or you load ketamine?
Question for me?
Yes, Dr. Susilo.
I never give midazolam anymore when we come to the enhanced recovery after surgery era. But in case the patient is very agitative, maybe we can give now dexmedetomidine intranasally is better than midazolam.
I see. So when you give
I want to elaborate more about the use of magnesium.
Oh, yeah, sure. Go ahead.
In my 5 years experience, that the Indonesian pediatric patient usually need less than the dose that Lucy gave. We only give 5 milligram per kilogram body weight. That is enough to make the blood pressure, the heart rate is stable, combined with lidocaine.
Can I ask Dr. Susilo, when do you start your 5 milligram per kg magnesium? Is it the start of surgery or midway to surgery or towards the end?
No, just after induction.
At induction. So at induction, you will start the 5 milligram per kg and it will last until after surgery.
Yeah, surgery, yeah. Except that the surgery is more than 3 hours, yeah.
Yeah, correct. So then after surgery, you will discontinue the magnesium.
No.
Okay, so you're not carrying it out in the
Yeah.
ward. Same, yeah. Okay, so we mentioned quite a number of potential adjuvants here. We mentioned about lignocaine infusion. We mentioned about magnesium. We mentioned about regional blocks, or it could be central neuraxial blocks. I think the main challenge now, right? Of course, intraoperatively, we are in command of our patient, right? Patient is monitored. We can rescue and as we see fit. Now the question is, what happened in the wards?
Yeah.
What happens next after the surgery? How are we going to manage this patient once we discharge this patient in either in wards or in ICU or in high dependency unit? Maybe let me start with Dr. Brushali. So for this particular patient, what is your post-operative pain intervention? You mentioned about targeted regional anesthesia technique, including central neuraxial blocks and epidural.
Yes.
What else are you actually going to give for the patient?
My notes would be as follows. I would have kept a lower thoracic epidural because the entire abdomen is going to get covered under that. So I would, depending upon the weight, it would again be, I'm not sure about the weight, but it should be 0.4 milligram per kilogram per hour of ropivacaine continuous infusion via an elastomeric pump, which is never tempered, well labeled. My team phone number would be written on it. Anybody can contact us, and of course we would be visiting. So we, along with the PICU people, would be managing the pain. We will have rescue boluses in place if at all required again. There is going to be, of course, acetaminophen given round the clock. NSAIDs we may avoid in this case. There could be some dilutional issues with coagulopathy. I'm not too sure which way we are going to go in this particular patient. After having a regional infusion, local anesthetic infusion going anyways, if at all now it is required, still if we are not getting a comfortable pain relief situation, then we definitely, we are not against opioids, but we want to minimize them. We could go, and the child is in a high dependency unit, so yes, or even a dexmedetomidine is a good option. But remember, the child might look agitated not only because of pain, but because of so many other tubes that are coming out, the nasogastric tube that would be there, the urine catheter, the stickings, pain on movement, which can get exaggerated. the mother being far, the bed not be the same. I mean, it's going to be many issues that the child is going to look grumpy with, not only the pain. So we need to segregate all this.
Yes, no. I actually like the fact that you have mentioned some critical things about epidural continuous infusion in the ward, that there should be some procedures and logistics policies involved that is in place, so that everybody must be aware on how they manage their continuous epidural in the wards and how they actually troubleshoot issues as well. So protocols must be in place. I have one question here in the Q&A. Will you actually consider neuroaxial ketamine as part of non-opioid management? Maybe I ask Dr. Bruchali, have you tried neuroaxial ketamine?
Neuraxial ketamine is off-label. It is not actually approved. So I would not recommend that. Clonidine is approved. Yes, I think by all means we can use it. However, there are studies on neuroaxial, even intrathecal ketamine for that matter. I think any drug that we know of has gone into the epidural space, but there is only one which is approved.
Noted. Yeah, thank you very much for that. Some logistic questions from our viewers. How do you manage leakage, soaking of dressing in epidural side? Do you use particular devices to prevent catheter dislodgement or maybe tunneling?
That's such a practical question. I thank you for asking that question. Addressing, there are certain epidural sets which come along with a good locking system. However, in children, for obvious reasons, there is always a leakage. A little bigger the child, lesser is the leakage. Okay, but it does happen. So dressing with proper gauzes, visit visit your own dressing. You might get a call because the bed is getting wet a little. So you may have to go and attend to that, enforce the dressing once again. And I have had incidences very initially where the epidural was just removed because they thought that it is leaking, and we need to communicate with them that this does happen. As far as tunneling happens, tunneling we restrict to areas where soiling is a possibility. Otherwise, we do not generally tunnel catheters which are put in lumbar or epidural places. Caudal catheters, we do think of tunneling for sure. So the tegaderms, all the good possible dressings that you have with you are the dressings that need to be put there, but we need to revisit our dressings also, the way the surgeons revisit their dressings.
Thank you very much, Dr. Bruchali.
And actually, in our practice, we also do use skin glue. I'm not sure if you do use that, Dr. Bruchali, but we do find that to be helpful at reducing leakage.
Sure. We call it derma bond, Lucy. Sometimes I've found it very difficult to get it out when I remove it. I mean, I'm not too sure if you have had that difficulty, but it gets stuck so badly. I mean, it's so efficient that it's difficult to remove the catheter.
Yeah, thank you very much for all the tips. Yes, Lucy, you were saying?
No. I think I had, that was the point I wanted to mention.
I think for this particular case, right, Lucy has highlighted earlier on about this is very complex pain patient who had numerous or some previous history of pain experience as well. And we are already at the part wherein we are managing this patient in the wards, recovering from this particular procedure. And Dr. Bruchali mentioned about she will carry on with some epidural catheter infusions as a pain regimen. Lucy, other things that we should actually focus on for this particular patient if we wish to achieve an opioid-free or opioid-sparing technique in terms of recovery, apart from pharmacologic intervention?
I think the key word there is multimodal. I think Dr. Susilo mentioned that earlier as well, that you don't just consider whether you give the patient IV lignocaine or IV ketamine infusions or IV dexmedetomidine or IV magnesium. You also give the typical analgesics, give paracetamol paracetamol, and in discussion with the oncology team and the pediatric surgeons, if they're willing, NSAIDs are also very helpful. And all of these strategies combined together with the regional anesthetic technique would give you your best chance of minimizing opioid use.
I see. Yeah. Thank you very much, Dr. Lucy. I think I'll give the same scenario that I gave from the previous case as well. So this particular case, we are successful. You gave lignocaine infusion intra-op, and then you have central neuraxial block, which is working very well, and you have patient and paracetamol. And then 6 hours later, the patient actually complained of significant pain. When will you consider to give an opioid rescue for this patient? And if you're going to give a opioid rescue, right, what are you going to give for this patient? Dr. Susilo, I know you shared earlier on your patient is very successful and went home without any opioid rescue at all. However, what is your threshold? What is your turning point to give an opioid? And if you are going to give an opioid, what is your preference?
So my experience, if the patient after 6 hours, you mentioned that the patient is in pain. So usually I start again to give lignocaine 1 milligram per kilogram bolus, and then drip 0.6 milligram per kilogram body weight per hour. And it's helpful. So that's why I mention always that I never use opioid again, because it works very well with lignocaine.
I see. Then how about Dr. Lucy, for you? What is your turning point to give opioids for this particular patient? What are the scenarios that you will give?
I think actually it's really a very case-by-case basis, because you do go and assess the patient first, and then you determine what is the likely source of the pain and how you should respond to it appropriately. Because, for example, if you have given a central neuraxial technique like an epidural, and perhaps you gave the bolus intraoperatively and you weren't running an infusion, then you started running an infusion. Maybe your epidural has actually worn off, and maybe you need to assess the band, and maybe you need to top that up. It's very case based, but ultimately, I think we still focus on making sure that the patient is comfortable. So I would give an opioid whenever I felt it was necessary, but it's case by case. It's a case by case scenario. And again, what Dr. Bruchali shared earlier applies as well. Could it also be a red flag? So yeah, every patient requires an assessment before treatment.
Yeah, Dr. Bruchali, your take? When are you going to give opioid for this patient? Are you going to? If you're going to give at all? Yeah.
Teddy, if this child is in my OR, what I would anchor analgesia around the epidural anesthesia and analgesia, because it's going to provide excellent pain relief. If it may not completely eliminate pain, so I would definitely go multimodal. So some degree of discomfort or breakthrough can occasionally happen, and I would manage it with, say, paracetamol. If it shoots even more than some discomfort, clinically significant pain, then I would reassess what the epidural is really doing, if the epidural is working at all well. Because a well-functioning epidural cannot give clinically truly significant pain. If it does, then I will ask myself, is it really doing its job? Has it come out? Or has it kinked? Or for some reason, has the pregnant elastomeric pump not deflating as per the expectation? So unless my epidural is not doing its job, I'm not going to think of opioids.
I see. Then, for example, Dr. Bruchali, let's say, because epidural, right? How long will you keep the epidural infusion for this particular case?
Easily for 48 hours, I can stretch it to 72 hours for sure.
I see. You can stretch for 72 hours.
For sure.
In your epidural, right? You mentioned about clonidine as an adjuvant. Would you add any other adjuvant to your epidural apart from clonidine? Will you consider putting opioids there as well, like fentanyl? Or no?
Yes, it's not that I've never added fentanyl into infusions. Yes, I have. I have stopped these days because mild discomforts can be handled by the IV paracetamol in a dose of 15 milligram per kilogram per hour. So I have kind of kept myself away from any infusions as such, but clonidine and fentanyl both are good additives in the infusion as well.
I see.
Yes.
But for
Yes.
this case, which one are you going to choose for this between the two?
I would still go for clonidine as an adjuvant, but after a particular time of infusion being going for say 48 hours, we do not know how much of the effect is by systemic absorption and
Right.
how much of the effect is by real target work on in the epidural space.
There's a very interesting question from Dr. Masao. I think I'll ask this to Dr. Susilo. If let's say we have this patient on epidural infusion, right, ongoing, and then suddenly the patient experiences some pain, then will you consider lignocaine infusion still as a rescue?
That's big question, good question, because yeah, it can double the risk of local anesthetic systemic toxicity. So if we already gave the epidural infusion, then better not to give like lignocaine IV. Maybe we have to change like ketamine or other that help like dexmedetomidine and drip after that.
Yeah. Dr. Brushali?
Yeah.
Yes, actually, Masao sir's question puts another thought in my head that nobody should even think of what Sushilo sir just mentioned, even intraoperatively. If we have given an epidural, then that is not the case to practice IV infusion,
I
even
like to our viewers.
IV lignocaine in the intraoperative period. Do not go to do that. And I just wanted to come back to the previous line. I just left the ends loose by saying clonidine. In the audience, if anybody wants to use it, the dose is 0.1 microgram per kilogram per hour. And that can go along with the 0.2% ropivacaine in the elastomeric pump so that nobody tampers your infusion.
I see. Yeah. Yeah, very interesting thoughts. And I think what we highlighted here are different regimens that our audience can use for this type of procedure. There are options, but they need to be mindful of what are the combinations and what are the safety features that goes along with it. And I think there are certain medications that we can use intraoperatively, like say magnesium, that we will stop using it or that we will discontinue before sending them out to the either high dependency or regular wards as well. And the options for local anesthetics, either you give by epidural or you can give it as an infusion. You cannot give both at the same time, if I gather it correctly from our speakers. Yeah, so those are the learning points that we learned from our options. I think from this particular, I have one more question, same question from the previous one, right? From the previous case. Should success, instead of using the recovery quality, in terms of success of treating this patient, are we using this recovery quality, or if we have successfully did not use opioid at all? So which one is you? If I don't use opioid, meaning I'm successful, or what is my success endpoint should be for this particular patient?
Patient-centered.
Okay, if I don't use opioids, I'm successful. I'm already a mature anesthetist according to Dr. Susilo. So what's your take on this, Dr. Susilo? Yeah.
Yeah, firstly, we must, in our mind, patient-centered, never our-centered, never doctor-centered. So think about the patient. If the patient happy, then it is successful. Happy means satisfaction, not painful, fully awake, can take some food. Not our. It's for patient.
I see. How about you, Dr. Brushali? Your take on this particular, because I know there's a lot of young anesthetists watching us right now, and like what Dr. Susilo mentioned, right, from opioid sparing, you promote to opioid free. So I'm wondering, so what will be your suggestion to our young viewers right now?
Yes.
Of endpoints of our patient. Yeah.
Wonderful. Roll up your sleeves. Go visit your patients in the postoperative period so that you understand how they appear. They should appear calm, or if not calm, reasonably you can comfort them, in other words. Number one. Number two, they should not be puking. They should not be under respiratory depressions. They should not be in apparent absolute pain. And so I think we need to give pain relief, which does not cause respiratory depression, which does not cause apnea, which does not cause nausea and vomiting, which does not cause hyperalgesia, which should be sustained, which does not have any side effects, which does not give any cumulative issues in the long run. I mean, in the number of hours that you're going to give. So now you suit what fits in your practice the best. This is the gamut that we have. Very difficult to achieve, but I think RA goes closest to it.
Yeah, thank you very much, Dr. Brushali. Yes, regional anesthesia is one of our greatest armamentarium for this. How about Lucy? Dr. Lucy, what's your take on this?
Sorry, Teddy, I was trying to answer the question
It's
in
okay.
the chat.
Yeah, we are just discussing whether in terms of if I am a new anesthetist, right, and for me to be able to, is it my measure of my success whether if I don't use opioid at all for this particular?
Oh no,
it
no,
actually-
of course it is always about the patient. Yeah, I
Yes.
would totally second Dr. Susilo's patient-centered care. Yeah,
Absolutely.
yeah, I would absolutely say that patient comfort is more important. And if that requires an opioid, then so be it. But of course, you do have many options before you go there.
Yeah. Yeah.
So let's hear from Joe. What is Joe's tagline here?
I think many things have been discussed, and I think, my takeaway points from listening in to everybody would be that, of course, we need to go multimodal. We need to time our medication well and appropriate use of drugs. There are also non-pharmacological methods to appease pain as well. And definitely, it's important to examine the patient and also to communicate well with the child as well as the person looking after the child, to understand where the source of discomfort is. I just have one question to the speakers as well. Like, often in neonates, morphine is used, for pain relief as well as a mode for sedation. So how do we then, move away from the use of opiates in that situation?
I think Dr. Joy is coming from a situation wherein the patient, neonatal newborn patient, intubated in NICU, then they will use morphine infusion as the main sedation and analgesia to provide comfort, to tube comfort, so that the patient will be comfortable with the endotracheal tube and the ventilation as well. I think the background from this is that majority of our neonatologists in the intensive care unit would prefer to start morphine infusion, a very low dose, but then of course it's still an opioid loading for a newborn patient. So I think what's your take on this? Maybe we start with Dr. Susilo.
Yeah, my experience is same like Joe mentioned that it is necessary to make the patient comfort. Again, patient-centered care should be the goal of our care for the patient. If it is the best for the patient, then we'll give morphine. Or now, more and more study do give dexmedetomidine for the case.
Yes.
So maybe we can move after that. I don't know. Maybe science is always moving. We have to catch up for that.
Yeah, I would also agree with Dr. Susilo that in this case of using it for sedation and tube tolerance, that maybe dexmedetomidine is actually more appropriate than morphine. And I think that bringing about the practice change, requires clinicians to actually become comfortable with using a new drug, because I think part of the problem is that morphine use is very well established and they are very comfortable with using morphine because that has been what they've used during training and very traditionally. But I think increasingly there is a shift towards using dexmedetomidine in this situation.
Yeah, I think we have learned quite a lot from our speakers and our panel with regards to various options of what we can use in order for us to avoid opioids and setting up realistic goals. With the two cases that we have shared, there are two complex cases, difficult to manage, very challenging. And I think for us, we need to identify whenever we need a rescue medication, we need to see and scrutinize our patient, review our current pharmacologic approach, consider non-pharmacologic approaches as well. And we need to be mindful that those medications that we are using to replace opioids is not devoid of any side effects. So we should be mindful about their side effects, their safety profile, and how they can be safely used in order for us to avoid creating a new problem with solving a new one. So therefore, from here, I will hand over the floor to Dr. Joe to close our session. Thank you very much.
Thank you very much, Teddy, and thank you very much to our panel of experts as well as Amrita for putting everything together. We've come to the end of our ASPA webinar. I'm sure many of you still have many questions to ask. Unfortunately, time is not on our side. So I would just like to thank the audience as well, for those especially who have stayed to the end. And just a couple of announcements before we end the session. So I think just a quick summary of what we have done in the last 1 hour. I think it is important that the goal is not zero opiates. Appropriate use may be more in line, and the goal for the right analgesia is important for the right child at the right time. So I'll go on to some announcements before we close the session. Just a reminder, certificate of attendance will be generated and forwarded to those who submit the post-webinar survey. The post-webinar survey will be released tomorrow. And please be sure that you put in your full name as well as the correct email address. Some announcements. There will be an ASPA webinar by the Pediatric Sedation Special Interest Group on the 19th of July at 5 p.m. Singapore time. Do tune in. Also, the European Airway Committee is asking for abstracts if you are keen to attend. And very importantly, the ASPA conference is on this year on the 10th to 12th of September in Vellore in India. If you have not signed up, please do so quickly, and also to submit any abstracts if you are hoping to submit any abstracts. So do remember to sign up for the ASPA conference, which is happening soon in later part of this year. Just a note to say that ASPA is a non-profit organization, and ASPA's mission is to foster the highest standard of pediatric anesthesia care in Asia. So if you have some spare cash, do consider donating to our cause in ASPA. So I'd like to end by thanking everybody for their attention and wishing everybody a very good evening ahead. Bye-bye.